All right, well, we might get started. Welcome, everybody, and sorry about our little hiccup. We've started a little bit early and you've got to see what goes on behind the scenes, but that's all fine. My name's Jenny Pearson. I'm the Professional Development Officer for the New England and I sit in Armidale. Just before we go any further, I'd like to acknowledge the traditional custodians of the land that we meet on tonight and pay respect to elders past, present and emerging. We have 4 presenters tonight, which will keep things very interesting and make it go very quickly, I'm sure. Our first presenter tonight is Dr. John Ferguson. He's the Director of Infection Prevention Services, a Senior Staff Specialist, Microbiology and Infectious Diseases for Hunter New England Health. So we might get started and you can take it away, John.
Thanks very much, Jenny. So just a very quick presentation and then we'd very much welcome your thoughts and comments and questions. Thanks. So a couple of slides from David Durheim, our Director of Public Health. So the first wave, of course, with the original Wuhan strain affected our elderly population overwhelmingly. That was because they were not vaccinated and it got into some very significant aged care outbreaks. Contrast that to the Delta Wave 3, which is affecting a much younger population group, the elderly population much better vaccinated now, just changing the whole epidemiology. However, the transmission is still largely occurring indoors, with household contact being the top level thing there, aged care and other venues, workplace included. So very little transmission out of doors. And, you know, most recently in Hunter, New England, we've seen 2 aged care outbreaks that have been contained without trouble because all the residents were vaccinated, and also a managed care home just in the last week. So you can see there the green represents household contacts, and this is the x-axis going from the 18th of July up to close to the end of August. But what about recent cases? So we're bubbling along largely below 20 cases per day in Hunter, New England, and Central Coast is very similar, possibly lower. Those lumps have been caused by the aged care outbreaks on the left and the managed care outbreak on the right. In John Hunter at the moment, today we had 10 patients requiring inpatient care, 2 of them in ICU, but those are Sydney patients who have been transferred up here. And already Gosford and John Hunter is receiving intensive care patients. The intensive care capacity is going to be vastly exceeded by really in the next 2 to 3 weeks. And so there's a lot of dancing happening at the moment in healthcare. We've got 100 patients under surveillance in the home. Contrast that to some locations in Sydney where they're dealing with 3,000 patients. Just imagine calling them every day. So 33 children, all of them well. That's children largely get off scot-free with this Delta strain, but there's a significant minority who come to grief. So Delta, highly contagious. You've heard the viral loads are much higher, 1,000-fold higher, and evidence of transmission during fleeting contact of unmasked people. We do believe, though, that the surgical masks used in indoor environments are very effective at containing transmission. We think there's an airborne transmission risk. I'll talk about that. It possibly causes more severe disease, certainly more disease in younger adults and children, but serious pediatric disease unusual. The vaccines still significantly reduce the chance of infection, and the breakthrough infections are transmissible. They have high viral load, but the viral load only goes on for 3 to 4 days, so the transmission's truncated. And the vaccines are still very effective at preventing severe disease. And you'll know that from the mortality data that's coming out of Sydney, the vast majority of deaths are in patients that have not been vaccinated. And the deaths in vaccinated patients have been in patients very elderly patients, usually with other comorbidities. What about aerosol transmission? By aerosol, I mean finer particles, classically less than 5 microns, but really particles up to 50 to 100 microns can remain airborne for quite some time and travel further from the patient. The finer those finer particles desiccate down to what are called droplet nuclei, and then can remain suspended for a long period of time and can be inspired below the larynx into the lung, where there are profuse ACE2 receptors. So really, with respiratory viruses, there's been this paradigm in the past about droplet transmission being responsible for most face-to-face transmission. And that's probably still the case, but equally airborne aerosols can account for that transmission. And we know that the SARS-CoV-2 virus is actually in that fine particle fraction created by the patient to a large degree. So it's quite probable that close contact transmission, unprotected, is occurring through a combination of droplets and the finer aerosols. Now, of course, both of those can deposit on surfaces and fomites, and you might possibly contact that and take it to your mucosal surfaces and infect yourself, but that appears to be a very rare route of infection. It's mostly through this droplet or aerosol. So in May, the infection control expert group did change its advice around COVID care to go to a P2 respirator standard for suspected or proven cases of COVID. So that's in high-risk settings like hospitals. Now, I'm just trying to see my slide again. So what about aerosol production itself? I think there's been acknowledgement now that even breathing in some individuals creates large amounts of virus, and speaking, particularly using plosive consonants. And there's a very funny viral video of a professor from UK there telling you about ways in which you can stop using plosive consonants. It's quite funny, very straight-faced. And coughing itself is highly able to create large quantities of aerosol, as is nebulization. The other aerosol generating procedures like CPAP, non-invasive ventilation, intubation, CPR, probably don't create significantly more aerosol than just normal living people. So that paradigm of having one infection control standard for aerosol generating procedures has really gone out the door. We just have one standard fits all. In terms of infection prevention controls, we'll get onto specifics for you guys in a moment, but in essence, there's a hierarchy of controls, immunization at the top, engineering controls, administrative controls, and then PPE. What about engineering controls? Well, this is becoming important because of the recognition of aerosol and virus and the need to maximize fresh air ventilation if we can, the need to spell rooms, small rooms, particularly things like elevators where these particles can linger and cause a subsequent infection risk to someone who's unprotected. Looking at airflows within care zones and locations to look to see whether there's an escape of air out of a room to, say, a clerical station. And really, we're trying to get negative pressure flow isolation put in place in our emergencies and hospitals. But the standard by which hospitals are built in New South Wales is a positive pressure single room standard. So single rooms are positive pressure to their corridors. So this we're trying to turn that on its head, which is very difficult to engineer, reverse engineer into our current settings. There's a vogue now to reduce airborne load at the source. So if you don't have a proper negative flow room, we put one of these HEPA filtered mobile air filtration devices that are quite quiet and just sit in the corner. They're very efficient at removing particles from the air, more efficient than a routine air conditioner. Administrative controls are probably the most important things. These are the sort of things you do at the front of your pharmacy to vet who is coming in and keep out the people that shouldn't be coming in. So training your meet and greet triaging staff and having a very good process there is key. And we've worked a lot on that in the healthcare setting. Managing and resourcing your staff, educating them, really, that's incredibly important. Managing the workspaces, training the staff, environmental cleaning, checking that the right precautions are in place. So walking around every day to check, watching for acute respiratory infection in staff and really empowering them to speak up. It's fantastic during this pandemic, the amount of staff coming to work sick has diminished, not entirely. One of the outbreaks we had a week ago was relating to a pathology collector working in Central Coast in 2 locations, 2 days whilst sick with COVID. That wasn't very helpful. Eye protection. So there are consensus recommendations for use. There's not robust evidence showing that eye protection makes a difference, but there is a reasonable amount of evidence pointing in that direction. So the COVID task force has come up with a consensus recommendation. No evidence that sealed goggles provide better protection. So it probably is the droplets that are important to stop getting on the eye. And there's a good eye practice points document there from the COVID task force, the evidence task force. Face shields, equally valuable to eye protection. So if you've got a face shield, that's fine. Now, surgical masks as source control have been really revolutionary across the world. I think the recognition that wearing surgical masks in every location to put a damper under transmission has been shown again and again to be a very effective measure. So just the masking of people to prevent them excreting infectious droplets or aerosols, they're very good at doing that. There's hamster models that validate this, and a properly worn surgical mask also provides source protection of the wearer from viruses, possibly not as good as a P2 respirator. So that source control, incredibly important. So that's what's happening when your clients come into the pharmacy unknown. They may be asymptomatically shedding respiratory viruses, and that surgical mask is dealing with that. We know with Delta that there is a significant pre-symptomatic excretion period of up to 48 hours, and those patients, or indeed young patients that are asymptomatic who excrete virus for 3 to 4 days. Other protective elements, of course, you'll know all of these, and I won't focus on these. There's good guidance out from the CEC about these things. I think staff COVID vaccination really damps down the anxiety around transmission incredibly. Certainly we've seen that in the healthcare setting. Our staff in our COVID wards are really just getting about business, not really anxious or concerned. They've got confidence in the vaccination, confidence in their PPE use. So it's really not a sweat for them this year. Cleaning and disinfection. So the virus is viable on surfaces for a period, but at low quantity. We don't really know if this poses a risk, I've mentioned. And I guess we don't like cloth furnishings in hospitals because we can't really clean them, except with steam. Touch surfaces and furnishings we need to think about, because that's really the locations that are going to cause infection, not the floors. So cleaning and disinfecting touch surfaces and furnishings. We tend to use single-purpose commercial disposable disinfectant wipes for that purpose. Obviously, the cleaner should be wearing gloves at least during that cleaning process. And we need to think through possible fomites, reused equipment, etc. And the other processes are routine. Waste streams, COVID waste goes into normal waste. It's not contaminated waste unless it's blood containing. and really laundry can be done in the usual manner. So this is the guidance sheet from CEC, which I'm sure you've seen, counselling that surgical mask use, not respirators, and eye protection for all comers, basically, with patients and customers wearing masks on entry to the pharmacy. So what about staff when they get exposed? So in community pharmacies, this will be subject to a population health risk assessment. So they will ring the case, they will ring and work out the close contacts of the case, the casual contacts of the case, and assess whether the venue was at a significant location or not. If so, the venue then gets attended to and you'll be interviewed. They'll look at your video if you have it available, and so on. And so they will basically do their assessment of the individual concern based on exposure, duration, environment, and closeness, whether there's source control, whether they wore, the staff member wore the correct PPE. And we follow a similar process in healthcare. There's a different risk matrix, which is linked to there, but that's quite instructive, I find, for even community settings. There is likely to be a nationally agreed risk matrix that will be used across community and healthcare settings, but not possibly for a couple of weeks. So there are my references, which I'm sure you've seen. The ATAGI website has a wealth of information. The CEC guidance there, and there's also guidance linked from the Pharmacy Society on the bottom link there, concerning vaccination clinics in community pharmacies. So I will stop there and hope I'm not over time. Is that okay?
No, not at all. That's great. I didn't mention there is a question box. So if you have any questions, just type them in. And Sandra's going to facilitate the questions tonight. Sandra is a clinical editor for Health Pathways with the Primary Health Network and a pharmacist. So please don't be shy. If you have any questions, just type them in and we'll do our best to get to them all tonight. Our next presenter is Patrick Cashman. Patrick is an immunisation coordinator with the Public Health Unit for Hunter New England Health. So Patrick, I'm just going to make you the presenter. And you are on mute, and that's your presentation showing now. Perfect.
Can you see that, Jenny? Yep.
Yes, I can.
G'day, everyone. I'm Patrick, or Paddy Cashman, from Hunter, New England, and nice to be able to talk to you tonight about vaccines, and good to see John had vaccines at the top of his hierarchy of measures. So just acknowledging we're meeting on Aboriginal land, and just interesting to remember there were over 700 languages in Australia before 1788, so very diverse place. So the virus, coronavirus, it's very tricky. So this is just a graphic from Nature, the virus's pathway and getting into the cells. So it meets the ACE2 receptor in your respiratory tract, and it's the spike protein that opens that ACE2 receptor and allows that virus to get in. And this grey area here is what happens in our cells. The virus bursts open like viruses do, the RNA comes out, and then you get many, many replications. Then that pops out of our cell. Then this is where our immune system meets it. So the antigen presenting cells, these funny shaped cells, present the virus to the immune system. Then a whole heap of cellular things take place. But the main thing is that there's two sorts of cells. There's the B cells down here, and they make the antibodies. The antibodies are always depicted as the Y-shaped things in diagrams, and they do that because they're Y-shaped. And then the T cells. So what a really good vaccine gives you humoral immunity or B cell immunity and antibodies, as well as T cell immunity. And then the B cell immunity forms long-term immunity memory. Now we can easily measure the antibodies, but we can't so easily measure the T cells and the memory cells, the memory B cells. So long-term immunity is really hard to judge, which is coming into play at the moment. So the antibodies are measurable. So what the vaccine does is it tries to replicate this process. So the virus infects us and of course pops out, and then it starts to stimulate the immune system. But what we try to do with the vaccine is have a harmless copy of that, and we typically use in COVID, use the spike protein, but there's many other proteins on the virus. About 28 other proteins, but we try to copy that spike protein. So all the vaccines really are trying to copy that spike protein and then stimulate your immune system in that way. So if you're interested in the pathway to get to where we are with all the different vaccines, there's a seminal paper last year from Katie Flanagan, who's an infectious diseases physician in Launceston in Tasmania. And we're going to talk mainly about the Moderna vaccine today, because it looks like that's coming in. So that arrives in the country on Saturday. The TGA will do batch testing. Normally takes 5 days, but the government's pretty keen to get that out to pharmacies pretty quickly. My understanding is that there is 3,600 pharmacies approved in Australia for Moderna. They'll be allocated vaccines in 3 tranches of 1,200 each, with about 300 and something coming to New South Wales in the first tranche. So that'll be sometime after Monday. I imagine there wouldn't be much hitting the shelves and the fridges by Monday, but after that. So that this vaccine will be, my understanding is, just at retail pharmacies. So I'll mainly be talking about the Moderna today, but of course you do have AstraZeneca at the moment. So it's just interesting to compare how the 2 vaccines work. So this is, of course, a depiction of the COVID virus with the spike protein, and the AstraZeneca uses the DNA. So it takes a little bit of the DNA and puts that in an adenovirus. So an adenovirus is a common virus. We all have adenoviruses every winter. It causes coughs and colds, or at least before we took on all John's methods of using masks and sanitizing our hands, we don't see as much winter coughs and colds, adenovirus infections as we used to. But this uses a chimpanzee adenovirus. It uses a chimpanzee adenovirus because if it used a human adenovirus, our immune system would recognize it and disable it. So it uses an adenovirus we're not familiar with. Then that gets the DNA into the cell, so that's the delivery package, and then the DNA is deposited into the nucleus and makes mRNA, and the mRNA comes out into the cytoplasm, and then it stimulates the ribosomes to make proteins, in this case spike proteins. But this is important because the adenovirus gives the DNA in the vaccine a lot of stability. So it's quite a stable vaccine as compared to the mRNA vaccines, as we'll see. But that's really just a contrast to what we see now with the mRNA vaccine over here. So this is what we really want to look at today. Now, what happens with mRNA normally? So the Moderna that you're going to get in your pharmacy soon. So if you ever forget what it is, the company, the name of their product is in the name of the company. So the last 3 letters are RNA, the first letter's M. So this company only make mRNA products. That's what they do. So this is what happens with normal RNA, messenger RNA. This is how it works. So this is not about the vaccine. This is about your cell. So obviously we've got DNA that we get from genetics. And then what happens is the DNA is only in the nucleus, but the ribosomes over here that make proteins are only in the cytoplasm. So we've got to get the message from the nucleus to the ribosome, and that's done with messenger RNA. Again, the hints in the name. So the messenger RNA takes a copy of the DNA and then takes that, and then the messenger RNA comes out of the nucleus into the cytoplasm of the cell, and then runs through sort of like a tape through the ribosome, and that has the code, and that will make a specific protein. So all the proteins in our body, in our kidneys, in our hearts, everywhere, are made this way, and the output is proteins. So what happens with the vaccine is that it doesn't deal with the DNA at all. It doesn't go into the nucleus. It's just here at the RNA stage. It's like a recipe. So it's giving you the recipe. So it's just the messenger of how to make it. So instead of a normal vaccine goes into the nucleus, like we saw with the AstraZeneca on the previous slide, and then the DNA copies to the RNA. Well, this skips that whole process, and as it happens, it's very efficient. So if you like, this is a slide from the company. So the DNA, if you have a computer analogy, is like the storage, the mRNA is like the software, and the protein is the application. So that's sort of how it works. Now now we're looking at how the vaccine works. So the messenger RNA is this little colored bit here. And then that's put into a fatty globule. And when we look at what's in the vaccine, we'll be able to see those fats. Now, the thing here is that's it. Like, that's very, very delicate, which is why you've got to treat it really, really carefully. So when you're working with mRNA vaccines, they're very, very delicate. So we saw how robust the AstraZeneca vaccine was in the adenovirus. This is just the messenger RNA floating around. It's in a little fatty globule. So it's incredibly delicate. So no shaking it. If you're drawing it up and you've got bubbles, you've got to be really, really careful. So really, really gentle, no shaking it, no banging it on the bench. This is a really delicate vaccine. Then the messenger RNA is deposited into the cell. And again, the fatty capsule around the messenger RNA allows it to slip into the cell, and then it doesn't have to deal with the nucleus, doesn't have to deal with the DNA. It's got the recipe here, and it runs through the ribosome like a ticker tape, and that will produce the spike protein, or the copy of the spike protein, which is then expressed on the outside of the cell, picked up by the antigen presenting cell, and then you've got your immune response like we saw on that first slide. So it's this bit here that is unique to the mRNA. So all the vaccines from here on are all the same. They're trying to make a copy of the spike protein. It's just the way they get there is so different. Now, what's been sort of a good outcome of the pandemic has been so much investment. There's a lot of new vaccines around and a lot of new technology. Now, what's in the Moderna vaccine? So the top line here is just the active ingredient, which is the mRNA. Then you've got 4 lipids that make that lipid capsule that the mRNA sits in to protect it a bit, but it's not very solid, so it's not great protection and allows it to slip into the cell. Then you've just got some acids, acid stabilizer, salts and sugar. So there's really not that much in it. And that means it's quite delicate, and there's really not much in it to react to. So it's not a very reactogenic vaccine at all. Now, the Pfizer does have PEG in it, and the AstraZeneca does have I've forgotten, stuff that's in soft serve ice cream. It's really, really common.
Polysorbate.
Thank you, polysorbate 80. Thank you very much from the audience. Save an old man. Yeah, so they're the 2 things that can cause a reaction to the vaccine. So it does have some ingredients in it, but not very much. Anyway, I'm not going to wax on lyrically about this to a bunch of chemists. But they're very, very delicate. So this is a picture of my garage with all the deep freezers in it with the mRNA vaccines. They do have to be kept well. So it's really up to you to keep them really well. So once they're delivered, really high quality storage is really, really important, and handling these vaccines are really important. So all the people who nervously turn up to your front door at your pharmacy, they've made a decision to come to your pharmacy to get the vaccine. It's really important they get a high quality product that's stored properly and kept properly and prepared properly. So what's interesting about so get me the right slide, is about mRNA, it is just a recipe. So this is to make a spike protein, but we can make other things. You can put in a recipe for something else. You can cook something else in your cell and tell the ribosome to make a different protein. So what if you're born missing a protein? The obvious example is hemophilia. So you could theoretically make an mRNA to tell the ribosome to make the missing protein from the cascade, the clotting cascade. And this is a paper from last year. It's only done in mice, but it's been able to be done. So this mRNA technology, which is new with the Moderna and Pfizer vaccines, is going to open up a whole sphere of medicine where we can make little recipes, put it in the cell, and then make missing proteins or therapeutic proteins, or in this case, vaccines. So it's not just about vaccines, mRNA technology. So it's really quite exciting. Now, we've got to make sure that vaccines are safe. So pharmacovigilance. So there's a mob called OzVac Safety. So I started a program 10 years ago after the problem with influenza vaccines in kids, giving them febrile convulsions. Vax Tracker, and we feed data into OzVac Safety, and they feed data to the TGA, and it's looked at every week. So this is active surveillance where we contact people after they've had a vaccine and ask them how they are. Now, OzVac Safety sent out over 6 million surveys to people around Australia, and we've got over 3 million responses. So these are big numbers, and we also have pretty good responses, over 44,000 from Aboriginal people, to get the sort of data, and it's telling us that most people have no adverse event. About nearly half, 45% of people report common adverse events like fever, fatigue, sore arms, but only a very small percent, less than 1% of people seek medical care. So on the weekends, I'm a lifesaver on the beach. So at the beach, we put up the flags and we say, if you swim here, it's safe. And pharmacovigilance is the same sort of thing. So we say, yeah, we're looking to see what happens. Yeah, there was the clinical trials with 30, 40,000 people, but they won't show up the very rare things when we give it to millions of people. So it's really important if you're going to give the vaccine that you're part of the vaccine safety program. So on the beach, if there's a rip between the flags, then we move the flags because the evidence is that it's dangerous there. And it's the same with vaccines. So Atagi said, let's give the Pfizer vaccines to people under 50. Oh no, more people are getting the AstraZeneca vaccine to people under 50. More people had blood clots, so they then made it under 60. So it's really important that we keep an eye on the vaccine safety. So this is data from the Pfizer vaccine, over 1 million responses, and 62% of people reported no adverse event with the first dose, but only 43% with the second dose. So with Pfizer, the second dose knocked people around with common symptoms like fatigue and headache more. Whereas AstraZeneca, it was the reverse. More people reported an adverse event with the first dose than the second dose. So this is active surveillance, but there's also passive surveillance. So if someone has, comes back to you, to your pharmacy and say, hey, you gave me that vaccine the other day and this or that's happened to me, some of those things that we need to then report. Now they get reported to the TGA. They get reported to the TGA. So one of the things with all pharmaceuticals, as you would know, everything you've got on your shelves is transparency and safety. So the TGA report, every week they put up a new report and they say, well, so far in Australia, we've given 17 million doses. We've had 52,000 adverse event reports. And so it's all transparent. So the message to the community is that if there's a problem with the vaccine, we'll find it and we'll tell you about it. There was a problem with the clotting, a rare clotting, TTS clotting with the AstraZeneca, and this is the data from this week from the TGA. There have been 6 deaths from the TTS, and in Australia, there's been 116 reports, 50 men and 66 women. So this is something that we found out about by doing good safety surveillance, and then we put it up on the TGA website so everyone knows about it. So people who are worried about things that aren't made public on the government websites are probably worried about something that that isn't real, because if there's a real problem, we want people to know. And we suspect that once you get the Moderna vaccine, there'll be a high demand for it because of this problem with the clots. Now, of all the vaccines given in Australia, there's only been 7 deaths. So the 6 reported here with TTS and another one from AstraZeneca with another ITP clotting disorder. So it's really important you report any problems that come back. So we've got the active surveillance in AUSVAC safety. So from the New South Wales Health website, there's a nice cascade about how to report, and it's really important we report anything that results in a serious adverse event. We don't need to report common things like fever, sore arms, and things like that. But if there is someone comes back to you and they've got an unusual event that needs reporting, you can report it directly to the PHU using the form on the New South Wales Health website. Or if it's something you're not sure needs reporting, but the person really wants to report it, the person can report it directly to the TGA so that they have satisfaction that it's been reported on. Now, anaphylaxis is something people worry about, but it's incredibly rare. There's a seminal paper in the Australian Medical Journal a few years ago, or quite a few years ago now, and it listed all the causes of anaphylaxis. Vaccines didn't even get a mention. Vaccines are a really rare cause of anaphylaxis, but you need to be looking out for it. That's why people have to wait around for 15 minutes, but you're only looking at about 4 per million. So when you give 1 million doses in your pharmacy, you can expect 4 of them to have had anaphylaxis. But it's really important that you're aware and know what to look for. So it's what happens in anaphylaxis is that you've got histamine and tumor necrosing factor and other cytokines in your cells. Your cells break open, and then because what happens is the IgE for some reason thinks that it's under attack, so the IgE proliferates. The IgE will then break open cells, and all these cytokines are released. And then because you get cellular breakdown, you get in the skin, you get like a bleeding type thing, so you get a red rash. You also get histamine released into your gut. You've got mast cells where the histamine comes out of line your gut. And so that's going to leak out into your gut. So someone who gets nauseous, we sort of normally dismiss nausea as a medical sign, but if someone's sitting there and they're getting quite nauseous after they've had the vaccine, that maybe they've got a gut full of histamine and they're cooking up anaphylaxis. But the BP drops, so that's a really important sign. So if you can take someone's blood pressure, that's going to give you a really good hint, because they've got reduced cardiac output. And of course, adrenaline will then reverse those signs. So it's very, if someone is developing an anaphylaxis cascade, it's really easy to reverse. But it's not like having a heart attack. You don't have to, as soon as someone has one of those signs that you're worried about, you don't have to get out the adrenaline and give it to them. Yep, because that's going to put them on a medical pathway that's quite difficult to manage. And there's other things that look like anaphylaxis. So there's one of these presentations a few weeks ago. The immunologist from John Hunter, Dr. Michael Boyle, presented on that. And if you want to know more about anaphylaxis, I thoroughly suggest that you go back and watch his presentation. He showed this slide, a study from Boston of 189 people with allergic symptoms with an onset between 1 and 4 hours. Now, anaphylaxis, remember, usually happens in the first 15 minutes. Now, they reported things that you might think looks like anaphylaxis, with flushing, erythema, dizziness, throat tightness, wheezing, and hives. Now, 159 of them agreed to have it again, and they were all okay. 20% reported similar symptoms, but it was managed quite well just with oral antihistamine, and 19 really thought they had anaphylaxis and then didn't with the second dose. So you don't have to go charging in with adrenaline all the time. If you do give adrenaline, it's really important you call an ambulance. That person goes to the hospital, because anaphylaxis can be biphasic. So you could give your adrenaline with a half-life of 7 minutes, then they feel fine, you send them home. But if it's true anaphylaxis, it could be biphasic, and then they're in all sorts of strife. So they do need to go to a hospital. Don't give adrenaline and send someone home, but think before you give adrenaline. You don't have to dive in straight away. It's not a heart attack. You've got minutes to make a clinical assessment. Don't withhold adrenaline if someone really needs it. There's a wonderful fact sheet from Victoria, from the Melbourne Vaccine Centre. And it goes through, so something that looks a bit like anaphylaxis is an acute stress response, where someone can get quite anxious after the vaccine, and they can usually be talked down with good care. So you need to be able to, if someone's freaking out after they've had the vaccine, you need to have the time to be able to manage that. But it's quite different to anaphylaxis, and I thoroughly recommend you have a look at this. And when you think about it, if someone faints afterwards, they get quite lightheaded and pale and faint, and that will happen nearly straight away, like within a minute or two of you putting the needle in the sharp spin. Whereas anaphylaxis, it's a cascade, so it's going to take about 15 minutes. Someone will feel quite hot and anxious, and they will be at you. So someone who just sort of faints in their seat, and you see them just collapse onto the floor, is more likely to be fainting, and that's going to happen quite soon after the needle. Someone with anaphylaxis is hot, flushed, they've got all this histamine happening and they're anxious, they're going to be at you and say, listen, I don't feel well, can you check me out? So the message is, you don't have to rush with the adrenaline. Don't withhold it if someone needs it. It is obviously life-saving, but anaphylaxis is incredibly rare, doesn't have to be front of mind in your clinic. Now, with the mRNA vaccines are associated very, very rarely with myocarditis and pericarditis, mainly in young men under 30. You need to be looking out for usually between 2 days to 2 weeks afterwards. So if a young person comes back to your pharmacy and they've had chest pains, palpitations, syncope, shortness of breath, they really need to go to hospital and get checked out with a 12-lead ECG. They need troponin taken and a chest x-ray. Now it's self-limiting, doesn't need treatment. Some of them can be treated with colchicine and non-steroidals. It's not life-threatening, and it's not an ongoing condition, but it is something you need to know about and to direct people that come back with this sort of presentation to the hospital and put in an adverse event report. So just a little bit on variants. So this is something that I saw in a presentation from a wonderful professor from South Africa, and a colleague of his. So this is the spike protein here, and I think this is a product of someone looking down the electron microscope too much. But he thought this spike protein looked very much like the sort of Adonis Greek statue here, the torso, with the left shoulder, the neck, the right shoulder, and the chest. So this on the right-hand side here is an early variation of the spike protein, but it still looks very much the same. So it still looks like the torso, and all the variations are like this. So the vaccines are still really good at recognizing all the variations so far. So even though the virus is varying a little bit, it's not varying so much the vaccines can't recognize it. Now, if there was a huge shift and the vaccines weren't working very well, then we just change the recipe of that mRNA, use the new one, and make a new batch. So variants aren't too much of a problem at the moment, so you can use those vaccines quite comfortably. So this was the original UK, this is B1, you would know from Australia, and this was the original UK variant, B117. Now, as you know, Moderna has been approved just the week before last for adolescents, so I think you're going to get a fair bit of demand when you get that in your fridges. And I'll finish up there. Happy to take questions afterwards. Thanks, Jenny.
Thanks, Patrick. We do have a few questions.
Would you like to do some questions now, Jenny, or did you want to go to John?
No, I would like to do some questions now, if that's okay.
Some questions. Fantastic. All right. And do we have John Ferguson still in the room?
No.
No, we don't. Patty, do you mind taking some of the infection prevention and control questions?
John would do it so much better, but yeah, I'm happy to have a go.
Fantastic. We've just got, the first one is around that the CEC PPE matrix that John showed, PPE for community pharmacies. And we've just had a question about that, you know, why, because I think a lot of the ones for general practice, they're recommending P2 masks if you're going to be in direct patient contact. But on the community pharmacy one, it's just the surgical mask. So what are your thoughts on that?
Yeah, I think yeah, that's a great question. I think John showed some good data that the surgical mask is incredibly good in the community situation. So where it's not a clinical situation where you're looking after patients who are positive COVID, in the community situation, the surgical mask is very effective, especially if both the person coming in to be vaccinated and yourself. And it's really not that much different to serving someone at a counter when you think about it.
And I actually was watching a webinar on Monday night, an RACGP webinar, and they were suggesting that when patients walk in wearing a cloth mask, rather than getting them to take off the cloth mask, to put a surgical mask over the top. Is that something you think pharmacists should be doing when people are coming in to get vaccinated into the pharmacy, wearing a cloth mask?
I don't know, but it sounds like a really good piece of advice. Absolutely. So yeah, so adding extra protection sounds like a really sensible idea. Yes, I think that's a great idea, Sandra.
Great. And just thinking about, I'm just looking through the questions and trying to summarise them a little bit, but just thinking about, again, that CEC matrix of PPE, they're saying that, you know, some sort of eye protection is required if you've got direct patient contact. But I'm just wondering, if you've got a positive case in the pharmacy, unknowingly, like poor John did on Saturday, although he had 6 of them, but if you've just got the one, and they're sitting in the pharmacy for their however long it takes to have the vaccine, and then their 15 minutes of observation, should all pharmacy staff be wearing eye protection? Because that was kind of the sense I was getting, that we should all be wearing it.
I don't know the right answer, but I would have thought yes. I would have thought in that situation. So John pointed out in his talk that the eye protection doesn't add a lot. It really is the mask is doing most of the work. But the eye protection does add a bit from droplets. And I would have thought, again, I would have thought yes. It's the customer you don't know of, who you need to be cautious of. So I would have so you don't know when to put your goggles on. So I think wearing them all the time is the right approach. That seems sensible. At the Belmont Immunisation Clinic run by Hunter New England, which is huge, in the old Bunnings down at Belmont, all the staff there are wearing eye protection. So I would have thought it's a reasonable standard for all the retail staff at a retail pharmacy.
Yeah, because pharmacies are considerably smaller than the old Bunnings.
Indeed.
And also just thinking from a business continuity point of view, if we did happen to have a positive case and public health come and had a look, I wonder if people not wearing eye protection might be more likely to be furloughed for 2 weeks than people who are.
Yeah, exactly. And I think John can probably talk to that better than I can.
Yeah. And so following on from that, we've got a question, and I don't know what your thoughts are on this, but whether face shields or safety glasses would be better.
Yeah, so John was ambivalent, I think, that face shields or safety glasses, they didn't need to be enclosed goggles.
Perfect. Now, the CDC have a video showing a knot and fold technique for disposable surgical masks. Is this a recommended practice?
I think if the CDC are recommending it, then it sounds like a sensible practice. Yep.
Great. All right, another one. Hey, Patty, are you able to comment on boosters and when they might be required in Australia, and ideally whether Moderna will be used? Thank you.
Yeah, that's a great question. So if there's boosters, it's likely to be an mRNA vaccine, because the AstraZeneca is in the adenovirus, and if we get many of them, we'll start to recognize it. So it's unlikely to be used as a booster. There's a paper in The Lancet just 3 days ago saying that, well, the evidence for boosters for everybody is not that clear. We probably don't have the evidence for population-wide boosters, maybe for people who are immunosuppressed, who don't respond to the vaccine really well. Obviously, ethically, we'd want everyone on the planet to have 1 dose before people in rich countries get their 3rd dose. But the evidence for boosters doesn't seem to be that clear. So the Israelis have started it, but now there's the according to this paper in the Lancet a few days ago, it needs a lot more thought. And possibly a better approach would be that if we're vaccinated and then we're moving around the community after we open up and we're bumping into COVID virus, that's going to naturally boost our immune system without boosters and without getting sick. So the jury for routine boosters is still very much out. Whereas a month or two ago, I thought it was in and we're all going to have boosters, but I think they're thinking more about it now.
Great. And a fabulous question's just come through from Luke Kelly. Thank you, Luke. What about, can you comment on the 4 to 12 week gap after the first AstraZeneca dose? Because I think there's a little bit of confusion in pharmacy about whether we are actually considered to be in an outbreak area, and should we be recommending 4 weeks, should we be recommending 8, should we be recommending 12, and how do we communicate that to patients around, slight decrease in efficacy versus getting your second dose in?
Oh yeah, just let the security guy know that everything's okay. All right, mate. Yep. Okay, thanks, mate.
Just being tortured by a bunch of pharmacists.
No, it's lovely. Yeah, so I think I think in Sydney definitely we're in an outbreak situation, and the shorter interval. Now with AstraZeneca and Pfizer that we have good data for, the first vaccine gives you like 40-45% protection, and the second one nearly doubles it, like over 80-85%, 90% protection. So that second dose is really, really important. So you really want to get that second dose in. So if you're in Newcastle where there's virus about, I would have thought 4 to 6 weeks would be a really good idea and not wait 3 months. If you're in Tamworth where there's not so much virus about, possibly you could wait, but maybe next week there's virus about, so that's a bit tricky. So I think the question is, are we in an outbreak situation? And that's the right question. So I think in Sydney, definitely yes. Newcastle, probably yes. In the rural areas, maybe you could wait. The trade-off is the length of immunity. So maybe the vaccine doesn't last as long if you jump in and have it at 4 weeks. Now, a month ago, I thought we're all going to get boosters, and I thought, well, that's a trade-off that doesn't really matter. But now maybe boosters aren't going to happen every year with influenza vaccine. So if there's no virus around, it's worth waiting the longer period. If you're in Newcastle, I would have thought getting that second vaccine as soon as possible makes a huge difference in terms of keeping people out of hospital and keeping people out of ICU.
Thanks, Patty. I'm assuming now that I'm seeing you, Jenny, that you want me to stop asking questions. Okay.
Yes, we're the clock's ticking away there, so we're running out of time, so we might go to our next presenter. Our next presenter is John Jones. He's a pharmacist and owns his own pharmacy, so take it away, John.
Real life presentation, right, because I am currently in lockdown or isolation for being exposed to COVID, and so hopefully I can give you some real world experience. So business as usual in a COVID pharmacy, and I think at the moment there is no such thing as business as usual. So the irony is, and for us, this tidal wave of COVID changing our businesses and the way we practice is quite substantial. And so I think at times you feel like possibly tapping out, but hopefully I'll take you through some really practical ways of managing and getting through this. So here we go. My first slide, I guess, depicts how important the whole team is as part of this process. In each pharmacy we have some wonderful pharmacy assistants, Webster, techs, and other junior staff who allow us to deliver services. And so, in this last week where I've had to self-isolate, my team particularly have been enormous in stepping up and ensuring that all of the systems and all of the services that we provide as a pharmacy is able to continue So, you know, I think, you know, mentioning names like Lauren Clay, who's my dispense second, some of the others have done a wonderful job. So I think you probably couldn't see my screen.
No,
now,
sorry, John.
Yeah, there you go. So I was just rambling. So here we've got a picture of the Knights, a Mad Keen supporter, and obviously they were knocked out on the weekend. But again, yeah, it shows that being able to deliver these services in the pharmacy is something that takes a team of people to do, and each person has a really important role to play. So we're going to go through systems and processes, a risk management framework, and you know, considering what things you need to have in place. What happens if you do have a positive case in the pharmacy, and what steps you need to take, and then I guess a small case study just to sort of you know, put some practical knowledge to it. So firstly, I think the most important thing about as a pharmacist is, what if you weren't there? What would happen, and how would the pharmacy run? How would you continue to deliver services and dispense medication? And really, this work should, and for most of us, has happened over years and months. So this isn't something that would have happened overnight. This would be something that you'd be working towards over a long period of time. We are mandated at the moment in New South Wales to have a COVID plan. So, you know, for me personally, until you're actually in that type of situation, you really do need to have some sort of framework to follow in terms of what you need to do. So if you haven't already done that, my advice is to, you know, put something together. There are a few templates around that you can use to help with that. So thinking about, firstly, what systems you have in your pharmacy, and how can you access those if you're not around. So things like rostering, how do you manage that? If you're using a piece of paper on the wall, that's going to be really hard to reference to when you're not there. Your patient management and dispensing, what services or what programs do you use? And fortunately, with Guild Care and MedAdvisor, you can access those remotely. Service delivery, so thinking about you know, how are you going to be able to implement that, and particularly putting in staff who are able and trained to do those jobs. You know, that's a really important thing about trying to fill those gaps. Having remote access, I know for me personally, it's been an absolute lifesaver. Without it, we wouldn't be able to manage. So that's something that I would encourage everyone to think about. What are your key pressure points? So what things in your pharmacy could you pull out and not do, or remove, and reallocate your resources and staffing to those areas, so you know that you're able to continue to run? And how can you get replacement staff? This is a big issue, and I think this is an issue that's sort of wider than just a COVID shutdown. I think in pharmacy we are having, particularly in community pharmacy, a problem with being able to keep and attract staff. They're being taken into other positions. So, you know, I think our incredible pharmacy assistants and Webster techs, you know, highly skilled individuals are often, you know, paid less than some other workers, NDIS workers that take people out for coffee. And I think this is something that really needs to get looked at, and obviously it's not in the scope of this presentation, but it's a really important consideration. So now thinking about your risk management and how you're planning for, if you know, try to reduce that risk of COVID presenting to the pharmacy. And I know some pharmacies, particularly larger pharmacies with bigger teams, have been rostering A and B teams, so that way there's no crossover from one team to the next. Often a very, very difficult thing to do, particularly when you've got sick leave or staff who are off, and then you have to get a replacement in. That particular individual can then cross over into another work team, which makes it, you know, really hard to manage that. PPE requirements. So as we heard in the last presentations about how we can reduce the risk of transmission between not only the patients, but in between staff as well, because we don't know who may or may not be infected. There's probably also a time to think about rapid antigen testing and its role. I know there was a presentation last night that mentioned that as one option for us to help identify those patients before they're turning up to work, and the cost of those is not out of this world. It's $10 or $11 per test, but again, that becomes a cost to the pharmacy, and obviously we wear that. That's not funded, or there's no incentives around that, but I guess it's something that helps with that protection. And probably something that's not specific to COVID, but staff burnout. I think at the moment, with the absolute demand that's been placed on us, and also trying to keep up with changes in legislation, new vaccination programs, it's created a huge amount of stress and pressure on all of our staff from the bottom up. So there's a risk that those staff won't be there because they are simply burnout and not coping. Planning for your pharmacy so that you're reducing touch points, and I think this is something that we've all been moving towards, so that we're looking at online orders, we're moving towards applications, phone apps where patients can order their prescriptions, e-scripts, so that time where patients are at the pharmacy is being reduced. Moving towards deliveries, documentation, so that patients aren't signing the prescriptions, they're not having to touch pens, they're filling out, and in our pharmacy, filling out their consent forms using iPads. They're not having to do that, and some of those jobs, many of them outside of the pharmacy, so again, that time and the number of patients in there isn't as high. Looking at cleaning cycles, so ensuring that the pharmacy is cleaned at regular points and sanitised to help reduce that risk. And I'll reference again, we've all sent before the PPE guidelines. I know this is the evidence guide, but in my particular situation, this was not helpful for whatever reason. Eye protection that I had on and the N95 mask that I also had on, and a gown didn't class as a risk reduction. So it's a really hard one for us as business owners and health professionals to manage when we're given this advice, and then sometimes those goalposts change, or obviously there's different factors, but we really need some clarity and consistency around this, I think. Okay, so we've done everything we can to try and reduce the risk of a COVID case, but what happens when the proverbial hits the fan? And I know it's everyone's sort of worst nightmare, and what steps do you need to take if you were exposed to a COVID patient in the pharmacy? Fortunately for me, I wasn't in the pharmacy, so it definitely helped with that sort of risk reduction, but nonetheless, there's certain steps that we need. So you'll be notified from the Public Health Unit, that's what the PHU stands for, or your employee will contact you to notify you that they have been classed as a close contact or a casual contact. So in that instance, if that patient has been there, and the population health units asked you to close for cleaning, then you'll need to follow their advice firstly, and then follow your normal closing procedure that you would do for any other occasion. Make sure you've got signage, obviously, to tell people what's happening, and put in place your phone redirection. If you don't already have remote access to your computers, can I encourage you all to make sure that you do tomorrow? First thing you do when you go in is you install an app like TeamViewer, or there's multiple other programs out there, but you will need to have that in order to be able to help manage the next steps. Cleaning, and so this is another important area of what do we need to do. So obviously before you reopen there has to be a thorough clean of the pharmacy. However, it doesn't have to be by an accredited cleaner. I know that that's sort of maybe the impression that everyone had, but it doesn't have to be. We are able to clean the pharmacy without that, and you don't need to fog the pharmacy, although they do look very impressive. Detergent and water followed by a disinfecting agent, or there is some 2-in-1 agents that are available, such as there's aseptic active. The TGA does have a list of accredited COVID cleaning agents, so you can get onto the website and find those. Safe Work Australia also has a cleaning guideline for the cleaning of a business. The next thing is about engaging with your team, and obviously the team is not just the staff but also your other health professionals that you're involved with. So firstly, making sure that you've got a way to communicate with them, and again there's a number of different means, and every pharmacy will have their own, whether it's a WhatsApp group, Facebook. Some of the rostering apps allows for that as well, so that you can provide that communication to all of your staff. Looking at your rosters, and then if you have staff who test positive and have to isolate, so thinking about which one of those positions can be filled by another staff member, how can some of those jobs be done possibly remotely, so just thinking about how you can put those things together. Communication. Really important that you keep everyone in the loop during this particular time. So before you start going out, obviously you want to sit down and plan a communication strategy so that you've got, I guess, some idea of timelines that you're going to have, how you're going to manage things like stage supply or other services that are provided in the pharmacy. Because just saying that we're closed is not going to be helpful, and in some cases it's just going to provide a lot more anxiety in your patients and other health professionals. So making sure that you've thought it through, you've got timelines and also actions that you can put in place to help manage those different services and other things that you provide. In terms of once that message has been put together, using social media, notifying the prescribers, PBS notification, and this is an important one. If the pharmacy is going to be closed for more than a couple of days, obviously that will significantly impact on the supply of medications, and so the PBS need to be notified. Using bulk SMS messaging services and email distribution lists is important. If you service either group homes or aged care facilities, it's also really important to speak with them about what's happened and how you're going to manage it, and what things you've got in place. And obviously these things should have been part of your COVID action plan so that you can put that into place if the time requires it. So continuing supply, and this is, I guess, the thing that creates the most angst for all of us, is how do we continue to do that? I guess firstly is ensuring again that you've got remote access to your computers. That will allow you then to at least dial in, look at patient histories, dispensing histories. If the patients need e-scripts, they can be sent via back to the patient, or other things like, for example, stage supply. So using programs like GuildCare, you can save the stage supply schedule so that you've got some idea of where that patient should be in terms of their stage supply. Putting in place something so that scripts on file are given to patients to be dispensed at other pharmacies. Looking at your opioid replacement therapy, and obviously the clinic, pharmacotherapy clinic, are very, very helpful with this type of problem, and rearranging dosing for those. Your DAA service, so you'll have Webster packs in the pharmacy there. How is that going to be able to be managed and supplied? And I did speak to Webster Care earlier in the week about moving the database profiles to another pharmacy if possible, if you're expecting to be closed for a significant period, and that can happen. So there are certainly some things that you can put in place to manage that. Hopefully it doesn't happen. And then I guess I'll just look at, this is more to do with a vaccination service, because I wanted to try and put that in as well. But how we go about that, how do we manage that, again, with the risk of COVID? And so the first step is obviously planning, thinking about your workflow, staff training, communication, and I guess the last thing is trying to create a fun workplace. And I put that in particularly because at the moment it hasn't been a lot of fun, and it's been very stressful on everyone. So trying to take moments to see the lighter side of things and have a bit of fun with the staff, I think is a really important part of this. So firstly, looking at your workflows, and when I was going through the process of putting our vaccination program together, I wanted to think about the steps that a patient would go through in being vaccinated, and again thinking about reducing risk. So how can we keep them out of the pharmacy as long as possible so that they're not spending as much time there, potentially exposing the staff. And I believe that as part of the risk assessment process by the public health unit is that they look at that. How long was the patient in contact and what risk that would provide? So looking at that and then taking them through those different parts of the pharmacy, thinking about the time that the patient will be sent. So if you've got one patient every 10 minutes and those patients have to stay in the pharmacy for 15 minutes, how many of those 15-minute waiting blocks can you physically keep in there? So that sort of turnover of vaccinations is a really important consideration, particularly when you're thinking about your own risk and the risk of, to the staff. So here is, I guess, in my case, using different IT strategies to help with training and communicating. So when I was going through the process of looking at how we would vaccinate, I was using some of our rostering systems and messaging systems to show the staff which part of that process they would be involved in and how to do it. So having a really good sort of training and communication platform, I think, is key to being able to make that work effectively. And then lastly, it's about, as I said, trying to keep things light and have a bit of fun at work. Obviously, we've had an enormous 2 years, and we've had attacks on pharmacy staff and close to burnout for a lot of people. So just, I guess, allowing your staff to share their stories, creating a positive and supportive environment is a really important thing to try and make that work. So that is the end of my presentation, and I hope you enjoyed it.
Thanks very much, John, for giving up your time, and I hope the rest of your time in lockdown goes quickly for you. Our next presenter tonight is a GP, Dr Ellie Warren. Ellie works at Yeren, and I'll hand over to you now.
Thanks, Jenny. Just having a look. Can you tell me if you can see my slides?
Yes, I can. You just need to start them.
Okay. Thanks, guys. It's really nice to be invited along tonight. My name is Dr Ellie Warren, and I'd like to start by acknowledging the traditional owners of the land from which we're calling in. I'm on Darkinjung country on the Central Coast, and I'd like to pay my respects to elders past, present, and emerging leaders. I'm going to be talking about our vaccine response in the Aboriginal and Torres Strait Islander community, and we're actually pretty concerned about what's been going on in the last 2-3 months. So we're really asking for your help as pharmacists now that we've got access to Moderna, to jump on board and help us vaccinate as many Aboriginal and Torres Strait Islander people as we possibly can. So we know that Aboriginal people are at higher risk of serious illness due to COVID, and this is multifactorial, but clearly because of the higher rates of chronic disease, complex comorbidities, higher rates of smoking, blood pressure problems, heart and lung disease, kidney disease. So they're really a very vulnerable group when it comes to this virus. And the community have done so well until only a couple of months ago to keep the virus out. And unfortunately, we've just seen it taking off in Western New South Wales and now here on the Central Coast and around Newcastle. So things are looking a little bit, well, for want of a better word, potentially catastrophic in the latest modelling that we've seen. So I guess it's really important for you guys to just be aware that this is an issue and we've got some catch up to play. So just looking at the case counts, really the main problem has been out in Wilcannia and Dubbo, Western New South Wales until recently. We've got some virus spreading through houses in the Central Coast now, and now that it's in those vulnerable crowded houses, it's going to be pretty hard to control. Similar things are happening around Newcastle now too, and Hunter, New England. So it's relevant to everybody. And this Delta strain is so contagious that once it gets inside a crowded house, then pretty much everybody will be positive. And we're finding that the contact tracing is difficult because some people are asymptomatic and the virus jumps to the next house, or when someone goes to the shops before we've identified the first case, and then we're sort of finding virus steps once removed before we've actually located the first case or two. So I think vaccination is going to be our main way to control it in the Aboriginal community. So you can see that the distribution of positive cases is mainly in the younger people. There's been some outbreaks in schools spreading around kids, so it's going to be really important to get vaccinating that 12 to 18-year-old age group. And pharmacists will be so essential to helping us out with that. So you can see this is the problem. So here is the vaccination gap, and I'll explain in the next slide why that is, but we're pretty concerned about those lower vaccination rates of fully vaccinated people. So this has changed drastically. Just in the last week, we've seen it jump 10%, which is amazing. People are coming in now to get vaccinated, but still in almost all areas across New South Wales, Aboriginal people are about 20%, 15 to 20% rate behind the rest of Australians in terms of being fully vaccinated. So yeah, Hunter, New England, vaccination rates as low as 24% fully vaccinated, which is pretty scary. So part of the reason for this has been certainly some hesitancy in the community early on, and that had to do with some mixed messaging and slow government messaging that was culturally friendly. So Aboriginal people really need that targeted messaging from their own community, using their own artwork and words and ways to portray these important messages. And we really did very well imparting the information around social distancing and staying at home, hand sanitizing. They've taken all of that on board very well. In fact, some of our elders have been in lockdown themselves since March last year, terrified to come out of their house. They've been very good at staying safe, but for some reason, the vaccine message has been really hard to get into community. Also, I guess they're traditionally a much younger population, and we know that the life expectancy is about 10 years less than other Australians. So only 9% of Aboriginal people are over 60 years old and would qualify for the AstraZeneca vaccine. When we switched to being able to offer AstraZeneca to the younger population, already that confusing messages, the messaging had just made it completely inaccessible. We've been pushing that through messaging from Aboriginal leaders and elders, speaking of the safety of the AstraZeneca vaccine compared to the risks of the virus, and for some reason people just won't have it. They're not going to have AZ. So now that finally we've got access to Pfizer, we've all been going quite hard over the last 6 to 8 weeks to try and play catch up with the vaccination rate. So people are definitely interested and keen to jump on board now. And there's a perception that Pfizer and Moderna, the mRNA vaccines, will be safe and acceptable in the Aboriginal population. So there's certainly been some mistrust of government, and that has a lot to do with the past policies, stolen generation, all that intergenerational trauma that compounds these issues of social disadvantage. Unfortunately, they've become quite disempowered, and it's confronting when government is telling people that you must do this or you're going to lose some of your freedoms. That's been a tricky thing to get our heads around. But also the, I guess, lack of awareness amongst health providers about how important it is to provide those culturally safe spaces for people to feel like they can enter into your door. So it's really simple to just put up some Aboriginal artwork or a poster to say, look, we acknowledge that, you know, we hear you, we understand, we're aware of the importance of being a culturally safe space. So we'll talk about that as well. And of course, we know that poor education, poor access to healthcare, transport problems, fear and shame, and certainly some issues about workforce shortage across the state, particularly in the Aboriginal medical services, just chronically short-staffed, and that has played a big role in being able to roll out the vaccine effectively. So what are the solutions? I guess you guys are going to be part of the solution, and just those really simple things you can do in your pharmacies to welcome people in, and making sure your staff are aware of things like particularly the closing the gap payment co-payment measure, that those CTG scripts are available to help Aboriginal people access the cheaper medicines, and we should all be offering that in every pharmacy. So unfortunately, sometimes we do hear back as GPs that a particular community pharmacy won't grant the CTG scripts, but that really should be something that everybody's doing. And the recent changes with PRODA and HPOS haven't altered any of the access benefits that people who have already signed up to the CTG program should be accessing those cheaper medicines still. So if you're not quite across those specifics, it'd be really great to reach out to PHN. There's an Aboriginal health liaison officer that could come and just talk you through that stuff if you're not comfortable about how to do it. It's just important. Another thing that just makes it that little bit easier for Aboriginal people to comply with their medication requirements and afford them. So thanks for your help on that one as well. But those culturally appropriate resources, you can see how beautiful that artwork is for the COVID vaccination program campaign, the awareness campaign. The artwork on the Aboriginal specific posters is much more exciting than the plain light blue on the standard posters. So even if you're not sure that you've got many Aboriginal people in your community, it's a lovely poster to have up on your wall, and it may just help that person decide to come in and get the Moderna vaccine from you. Other things that work really well is having an Aboriginal health worker on site. So you could reach out to the PHN or your local AMS to see if you could borrow someone, and even think about running a special clinic for Aboriginal people on a particular afternoon. They love celebrating together. They love doing that, and they're used to doing that in a COVID-safe way. And the TGA has recently relaxed some of the rules about incentivising to get people into the door. So you could offer them, you know, some biscuits or a T-shirt or a little prize for coming in to get their vaccine. That's perfectly acceptable. So they love to celebrate together, and if it's about being well and preventative healthcare like immunisations are, it's a really nice way to get to know your local community and start to champion some of these equality issues. So that would be really important. And I guess also to be aware that every Aboriginal community is different, so across the state, and we just need to just tap into the local community, reach out to those leaders through the AMSs or the Land Council or the PHN if you're not quite sure where to start, to just really understand what the local community needs from you. So if you chat to them and find out what they want and how to do it, and then once you have their help, then they'll actually get people into the door for you, and it'll work really beautifully. Another simple way to do engage with the community is just to share the local Aboriginal Medical Services social media posts. So many of you will have your own Facebook page and your own Instagram page possibly. If you follow your local AMS or even just the AH and MRC or Nacho's Facebook and Instagram pages, that's a really nice way to have these culturally friendly, specific posts to say, look, you know, we're aware that sometimes it's a bit daunting for you guys to get your vaccines, but we're open to seeing more of community and want to help you out. So share those messages, like and comment on their posts, and that shows community that you really mean business when it comes to their health. And nothing beats that direct messaging from the community themselves. Yeah, so thanks everyone. Hopefully that catches up a little bit of time, and yeah, let's have some questions if you have any.
Thanks so much, Ellie. That was really lovely. A very beautiful presentation. I'm going to show my screen just so that you can have the Health Pathways login details. Can you see them now, everyone?
Yes, we can.
Yeah, great. And I'm just going to leave them up. We don't really have a lot of time to go through Health Pathways, but on the left of your screen is Hunter New England, on the right is Central Coast. Pretty much every resource everyone's put up tonight is on one of those, one of the Health Pathway pages. But we've got a whole suite of COVID vaccination pathways, and we've got the COVID information page that has all the PPE and infection prevention and control. But I really want to get to some of these questions because there's some really interesting ones here. And apologies if we go a little bit over time. I'm sorry, Patty, but I think some of these are fairly important. And it's just suddenly got very small on my screen. But one of the things a couple of people have been asking about is about how long. So with the Moderna vaccine, the company is claiming a 19-hour viability after first using the vial. However, Atagi is saying, someone just posted a question and it went off my screen. But Atagi, I think, is saying 6 hours. Can you, Patrick, comment on that, Patty, like the what to do with the Moderna?
Oh, yeah, I think we have to follow the Atagi advice, Sandra.
Okay, and that's 6 hours, is it? Sorry, I've lost the question. Okay, fantastic. Hopefully, pharmacists, that answers your questions there. And given the fact that one Pfizer or AstraZeneca vaccine confers minimal immunity for the Delta variant, is there any benefit to delaying second dose Pfizer shots? I don't quite understand this question. Is it better to have 200 people with first dose with a 6-week interval, or 100 people with 2 doses and a 3-week interval?
Yeah, it's a great question. So we've done variations of them all. So in Sydney at the moment, a few weekends ago, they had a big push through the big hubs in Western Sydney, and they decided to delay Pfizer rather than using the conventional 3 weeks to use 2 months for exactly that reason, so they could get more people with dose 1 rather than half the people with dose 2. So programmatically, that has been done. At your pharmacy, it really depends on what's happening around you and how much virus there is. I would have thought using the shorter interval to get people in for their second dose is probably the best advice at the moment, to get as many people double vaccinated. I think from it, yeah, so programmatically, that's sort of for the health department to decide what they're doing from that. But from your point of view, the advice you would give to individual people coming in would be to come back at the minimal or just over the minimal interval.
Mm-hmm. And another question around the Moderna, if the patient has, and I suppose this will be quite important for pharmacists because we will have both AstraZeneca and Moderna, if the patient has no contraindications or precautions to either AstraZeneca or Moderna for a 70-year-old, do they have a choice?
Yeah, no, that's a really good question.
That's a very good question. It's been one of my burning questions. I was assuming that if over 60, they wouldn't be allowed to get the Moderna, but I'd love to hear what the advice is.
Yeah, that's right. So at the moment, the advice is if someone's under 60, we give them an mRNA vaccine. So we'd give them the Spike vaccine, the Moderna vaccine. If they're over 60, we'd offer them the AstraZeneca. I think going forward that advice will change as the supplies of Moderna and Pfizer increase. The appetite for asking people over 60 to only have AstraZeneca will change. Now, like all medical decisions, it's a risk-benefit profile. So the risk of clotting from the AstraZeneca is at its peak in the 40-year-old age group and decreases dramatically over 60 to less than 2 per 100,000. But the risk of the disease dramatically goes up over 60. So the risk-benefit profile for people over 60, AstraZeneca is clearly a good idea. For people in their 40s, not so much. As the supply changes, possibly that advice will change. But at the moment today, I think you'd be asking the 70-year-old to have a AstraZeneca vaccine. But that may change going forward.
Excellent. And this is a question to either the PHN or to New South Wales Health. So Patty, I don't know if you can represent New South Wales Health on this, and I don't think there's anyone that can represent the PHN on this question. But one of the pharmacists has written that they've actually got like John, they've got a pharmacist who was with a COVID positive patient, so he's out for 2 weeks and he's getting very nervous about it. And they're asking, can we use your property somewhere to run vaccination clinics, because they're getting very nervous to allow people into the pharmacy for 20 minutes if it risks shutting down the core business. And the question is, what can they put in place to stop that happening? And I suppose that will all depend on the sort of PPE that's being used, would it, Patrick? Sorry, that's a whole lot of questions for you there, Patty.
Oh yeah. So this goes across a whole heap of disciplines of which I don't represent fully, but I think it goes to John's excellent point that raises he's followed the advice of wearing the correct PPE, but when he was exposed to a positive patient, he was still asked by the public health unit to stay at home for 2 weeks, and I think that's a conundrum. I don't have an answer. I think that's a really good point, John, and probably I should catch up with you afterwards about that and clarify that for pharmacists out there. I think that's huge.
Yes.
But yeah, so at the moment, there's lots of properties being used for COVID vaccination clinics, so we don't have spare ones for pharmacists just to use. I don't know whether. So I really couldn't address that question, Sandra.
Yes,
we've been really excited about pharmacists coming on board because they're sort of everywhere and where people are, and I'm really hoping it's going to improve the vaccination rates. I think this is very exciting.
And perhaps we need to have a conversation with the PHU about, what is it that pharmacists can do to really ensure business continuity with their PPE and their practices, so that if a positive patient does happen to walk in, that they're covered. Because I know, Ellie, I've been on the GP community of practice chat and hearing all those stories about GPs finding themselves vaccinating or being in the room with COVID positive patients, and some of them have managed to continue with business as usual. So I think that needs some clarification, and certainly we can liaise with the PHU about that. And Ellie, there's a lovely comment for you. Ellie's tips about making the pharmacy welcoming for the community are beautiful, and hope they make it easier to get the community in to engage. So thank you so much for sharing that with us. And someone else has asked, they've missed the first 30 minutes but would love to look at the video if available. Yes, it will be available on the PHN Education Library, probably from tomorrow, I would say. I'm just having a quick squeeze through. I realise we are out of time, and I don't want to hold up any of these beautiful people any longer, because I think you've all been amazing. I think we've covered the main questions. Someone missed the beginning of the talk, Patty. So you're saying you can contact COVID through the eyes. I missed the first part of that talk with John. Can you please clarify?
John was saying not so much. It really is respiratory, droplets and aerosol. He was talking, but when he was talking about the eyewear, a shield and the goggles are equivalent. It's about stopping the droplets. It adds a little bit, but not nearly as much as the mask. So yes, you don't have to be, I think the message was some eyewear, but you don't have to be too fussy about it. Getting COVID through the eyes is not as, it's not going to happen as much as breathing it in. Yeah.
Beautiful. And possibly the last question, maybe, where did it go? Would you recommend ibuprofen as a preventative for myocarditis? And just before you answer that, either Patty or Ellie, we on Health Pathways, we've got a range of COVID vaccination pathways. We've certainly got one for the TTS adverse effect, and hopefully very soon we are working on a pericarditis and myocarditis post-COVID vaccine pathway. So hoping to have that up fairly soon. And Patty did, sorry, I'm just going off on a bit of a tangent here. Patty did talk about adverse events following immunisation reporting, and we worked very closely with Patty and the team at the PHU to really carefully articulate how you can do that. So please do go and find that on Health Pathways and follow the steps. But back to the question, do you recommend ibuprofen as a preventative for myocarditis?
No, so the myocarditis is incredibly rare. So you'd be treating an awful lot of people with ibuprofen unnecessarily. So it's not a good practice. The signs and symptoms are clear. It's self-limiting. It does need investigation. People do need to go to hospital, but it's not terribly serious in that sense. So no, we just find and treat the people who need it. Don't just spread it liberally around just in case.
Beautiful. Thank you so much. You are all such terrific people. Thank you for giving up your evening to support the pharmacy cause for vaccinating. John, we wish you all the best in your 2 weeks of isolation. Hope you stay sane. And there's been, beg your pardon?
8 days to go, and I'm
8
not
days
counting.
to go. And there's many questions coming in that are just saying thank you all so much, great presentation. So thank you all so much. We are so blessed to have such great clinicians in our footprint who are so willing to give up their time and who are so wise and so intelligent and such great presenters. Sorry, Jenny, I'm probably doing your job here. Did you want to take over?
I would just like to say thank you to you, Sandra, for facilitating the questions tonight, and yes, to all our wonderful presenters. It's been a very engaging talk. Don't forget the recording will be on our website, and you'll get a confirmation email tomorrow. It will have the link to the site, our education library. So it should be up by tomorrow afternoon. Thanks everybody, and have a nice evening and stay safe.
Bye-bye. Thanks so much.
See you guys.